Abnormal Psychology, 4th Canadian edition, Chapter 3, Classification and Diagnosis. Prepared by Tracy Valancourt, Ph.D. Modified by Réjean Dupuis, M.A. Diagnostic System of APA, 5 Dimensions of Classification. Axis 1. All diagnostic categories except personality disorders and mental retardation. Axis 2. Personality disorders and mental retardation. Severity. For Axis 1 and Axis 2, can code severity either in some diagnostic categories, for example mental retardation, or using specifiers. Mild, meets criteria for the diagnosis, however, few additional symptoms. Moderate, between mild and severe. Severe, either has many more symptoms than required for a diagnosis. Some of the symptoms are particularly severe, for example suicide attempt, or daily functioning, school, work, family, is severely affected. Can also note the following for Axis 1 or Axis 2. In partial remission, patient no longer meets full diagnostic criteria. Some symptoms still remain. In full remission, patient has been free of symptoms for an extended period of time. Prior history. Patient no longer meets criteria for this diagnosis. However, it is clinically prudent to include this diagnosis. Axis 3. General medical conditions. Lists any physical disorders believed to have bearing on the mental disorder in question. Axis 4. Psychosocial and environmental problems. Problems the person has been experiencing in these areas. Axis 5. Current level of functioning. Rates the person's current level of adaptive functioning. Axis 4. Psychosocial and environmental problems. Examples: problems with the primary support group, death of a family member, problems related to the social environment, difficulty with acculturation, educational problems, discord with teachers, occupational problems, unemployment. Axis 4. Psychosocial and environmental problems. Examples: housing problems, homelessness, economic problems, insufficient welfare support, problems with access to healthcare services, inadequate health insurance, problems related to interaction with the legal system, incarceration, other psychosocial and environmental problems, war, natural disasters. Axis 5. Global assessment of functioning. Clinical judgment involved in Axis 5. How is the patient doing, overall? 100-point scale, divided into 10 ranges. GAF, Adult Scale. CGAS, Children's Global Assessment Scale. GAF, adapted for children. Can also report the time period that the rating encompasses. Current, highest over past year. At admission. At discharge. This multi-axial diagnosis is believed to provide a more multidimensional and useful description of the client's mental disorder, used to report all 5 DSM axes in a systematic, organized way. Ideally, when you are diagnosing a patient, you should include a 5-axis diagnosis. Example: Table 3.1. DSM-4 Multi-Axial Diagnosis of J. Brett Barkley. Axis 1. Alcohol dependence. Alcohol-induced sexual problem with impaired arousal. Bipolar 1 disorder, most recent episode. Manic, in full remission. Partner relational problem. Axis 2. Avoidant personality disorder. Axis 3. None. Axis 4. Problem with primary support group. Axis 5. GAF, equals 55. Classification of disorders continued. Substance-related disorders, schizophrenia, mood disorders, major depressive disorder, mania, bipolar disorder, anxiety disorders, phobia, panic disorder, generalized anxiety disorder, obsessive-compulsive disorder, post-traumatic stress disorder, acute stress disorder, somatoform disorders, somatization disorder, conversion disorder, pain disorder, hypochondriasis, body dysmorphic disorder, dissociative disorders, dissociative amnesia, dissociative fugue, dissociative identity disorder, depersonalization disorder. Classification of disorders continued. Sexual and gender identity disorders, paraphilias, sexual dysfunctions, gender identity disorder, sleep disorders, dysomnias, parasomnias, eating disorders, anorexia nervosa, bulimia nervosa, binge eating disorder, factitious disorder, adjustment disorders, impulse control disorder, intermittent explosive disorder, kleptomania, pyromania, pathologic gambling, trichotillomania, personality disorders, schizoid personality disorder, narcissistic personality disorder, antisocial personality disorder, etc., delirium, dementia, amnestic, and other cognitive disorders. Gambling in Canada. Increases in gambling problems due to legalized gambling in several provinces. Prevalence rate of 2 to 4% for those at risk. Opening a casino increases gambling activities and negative consequences of gambling. Low-risk gambler, gambling 2 to 3 times per month, no more than $500 to $1,000 per year, or less than 1% of annual family income. Online problem gamblers have more problems than social gamblers. Who is likely to gamble? Problem gamblers are more likely to be male, single, under the age of 30, and to have begun gambling before age 18. Those with gambler fallacy, the belief that one is more likely to win after a series of losses. Youth are at risk. Youth are at greater risk than adults. Characteristics of youth gamblers in Toronto: male, out of school, working for pay, alcohol, marijuana use, severe dating violence, carrying a weapon. Prevalence rates in students in Atlantic provinces are 8.2% for at-risk and 6.4% for problem gamblers. Consequences of gambling. For families: dysfunctional relationships, violence and abuse, financial pressure, disruption of growth and development in children. Male and female adolescent severe problem gamblers have similar rates of depression, substance use, and weekly gambling, linked to attempted suicide. Positive note: gambling is not always progressive and enduring, contrary to conventional and professional wisdom. Treatments for pathological gamblers. CBT, impulsivity, interferes with staying in treatment. Controlled gambling has shown efficacy in 35% of problem gamblers in 2-year follow-up. Only 20% of adolescent problem gamblers admit having a gambling problem. Prevention. www.youthgambling.com, International Center for Youth Gambling Problems and High-Risk Behaviors. www.knowthescore.ca, Responsible Gaming Council and Canadian-U.S. Universities. Classification of disorders. Disorders usually first diagnosed in infancy, childhood, or adolescence, separation anxiety disorder, conduct disorder, attention deficit hyperactivity disorder, mental retardation, listed on Axis 2, pervasive developmental disorders, learning disorders. Important concepts: epidemiology, prevalence, lifetime prevalence, comorbidity. Prevalence of mental disorders in Canada in 2002. 1 in 10 people with symptoms of depression or anxiety or alcohol drug dependence. 1 out of 20 people met the criteria for depression or bipolar disorder. 1 out of 20 people with panic disorder, agoraphobia, or social phobia. 1 in 30 met criteria for substance dependence, alcohol or drug. 1 in 50 met criteria for at-risk problem gambling. Eating disorders and agoraphobia 5 times higher for women than for men. 2/3 of young people ages 15 to 24 with depression and anxiety stated that their first symptoms started before age 15. Half of people ages 45 to 64 and 1/3 of seniors reported that their symptoms began before age 25. Criticisms of classification. General criticism. Loss of information about the person. Stigmatizing. Specific criticisms. Discrete entity versus continuum. Dimensional classification versus categorical classification. DSM represents a categorical classification, a yes-no approach to classification, continuity between normal and abnormal behavior not taken into consideration. Reliability. Reliability is the cornerstone of any diagnostic system. Inter-rater reliability. Validity. Validity of diagnostic categories. Construct validity. Diagnosing at a crossroads. The DSM revision process evaluated 2 alternatives: reorganizing the diagnostic classes, implementation of fully dimensional schemes. A hybrid system. The DSM-5 will be a mixed categorical dimensional system. Axes 1, 2, and 3 will be collapsed. Changes to Axes 4 and 5 are being considered. Some diagnostic criteria are being revised to include gender, race, culture. Metastructure, including shared risks, for example, genetic, environmental, and clinical factors, for example, comorbidity, treatment response, are evaluated. Internet addiction disorder. IAD is considered for inclusion in the DSM-5, includes excessive gaming and email text messaging, shared components, excessive use, withdrawal symptoms, tolerance, negative repercussions. In Block's 2008 study, 86% of IAD cases also had another DSM diagnosis. In Asia, therapists are trained to screen for IAD. In South Korea, 2.1% of children ages 6 to 12. 80% of those requiring treatment need psychotropic medication. 20% require hospitalization. 1.2 billion are considered at risk as they spend 23 hours per week